episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, once again to another episode of our show with another truly fascinating guest who is helping to create a better tomorrow for all of us. We're honored today to be joined by Dr. Rebekah Gee, who is a clinical professor in obstetrics and gynecology at Louisiana State University School of Public Health and Medicine, and the Chief Executive Officer of LSU Healthcare Services. Dr. Gee formerly served as Secretary of the Louisiana Department of Health, the state's largest agency with a budget of $14 billion. And while as Secretary, Dr. Gee oversaw the implementation of a variety of programs, including Medicaid expansion, which extended coverage for over 500,000 Louisianans. She developed the first in the nation elimination campaign for hepatitis C, led national policy discussions on the creation of affordable pharmaceuticals, eliminated decades-long waiting lists for individuals and families needing disability services, implemented an aggressive statewide opioid response plan, as well as a statewide standing order for Naloxone, which has saved thousands of lives throughout Louisiana. Dr. Gee is also a champion for health equity. She created the South's first Office of Health Equity in the State Department of Health. Throughout her career, she's been a consistent voice for maternal safety and quality. Before her time as the Secretary, she served as Chief Medical Officer of Louisiana Medicaid, and previously served as the Director of the statewide Birth Outcome Initiative and led the charge to decrease infant mortality and premature birth statewide. Dr. Gee is a policy expert, widely published health services research on numerous additional state and national policy roles. She currently continues to practice and see patients. And when she's not doing all of that, she's also the mother of 5 children. So she has a lot on her plate. Dr. Rebekah Gee, thank you for taking the time to come on our show today.
Thank you, Ira, for having me.
It's a real pleasure. Typically, we start things off by just handing our guests the floor for a little bit to further introduce themselves for a few minutes. If you could sort of just take us back a little early in the story, a little bit about where you grew up, when you first developed your interest in public health and medicine and obstetrics and gynecology, and a little bit about your early career journey. I think that'd be a great way to start things off.
Sure, Ira. So unfortunately, I've had some personal tragedy and loss, which have motivated me to be an advocate for healthcare. So when I was 15 years old, my mom was diagnosed with breast cancer, and she died shortly after my 16th birthday. And it was my experience with her cancer and the physicians who cared for her that helped me make my career decision to become a physician. I wanted to become an OB because of the issues of impacting women were so compelling, whether, access to contraception, making sure women had adequate pain management in pregnancy, but also just what a beautiful thing it was to be the first person to see an infant's eyes open at the very first moments of life. Well, it was just it was a beautiful profession, and I've been so glad to have that be a part of my career. And then as I went through residency, I fell in love with a wonderful man named Alan, who was a resident at Mass General at Harvard, like I was. And unfortunately, we were on a scooter and got hit by an SUV, and he was killed. And I spent then 3 months in a wheelchair. And so it was through my experience losing Alan, but also me really needing healthcare. Frankly, without it, I would definitely not be walking now. I had a paralyzed left arm, 18 broken ribs, double femur fracture, ACL tear, meniscus tear. My dad used to call me Humpty Dumpty. So anyway, it was the healthcare I received that saved my life. I mean, because at one point my dad got a call when I was in the ICU, and they said, "We can't save your son-in-law, and we might be able to save your daughter." Mm-hmm. So I have since that time, of course, been so aware that there by the grace of God go I every day is a gift, and that there are many people in this country that don't have health care. And for them, they're not as lucky when something bad happens. And so my advocacy for them comes both from my personal experience as well as my professional practice. I'm a physician. I continue to see patients, and I see patients every day. And some of them, because of racial bias, I saw a patient last week, frankly, who had breast cancer, should have been caught earlier, should have been examined. She's a young Black female, and I don't know if it was racial bias, but it certainly wasn't the best care she could have received, and now we're dealing with a terminal sentence for her. So it's those stories, my patients who who have entrusted me with their care, they really are the reason why I do the advocacy that I do. And what I love about being a policymaker is I can see things in the office, like the care that my patient received, and then I can take the solutions to a population level and help many thousands of people. So it really is, been a wonderful career. I am the great granddaughter of a Mormon prophet. Grew up in the Mormon church, in both parents from Utah. Okay. And I do think that the Mormons grew up with a very clear sense of right and wrong. And I do continue to have that. I really am irked by inequities. I'm irked by things that are wrong. I believe that lack of access to health care in a nation that is the wealthiest nation on earth is an unacceptable fact. And so I've worked to try to change that. I think most importantly through the expansion of Medicaid here in Louisiana, which about 500,000 people benefited from. And certainly with the COVID epidemic, it was a critical, a very critical resource that not only paid for testing, but paid for COVID treatment. Mm-hmm. And so I think that one doesn't have to make the arguments about why healthcare is important in a post-COVID era as you did need to do prior to COVID. So that's my story. I'm a daughter. I'm a mother. We have 2 sets of twins. I have 8-year-old girls, and then my step babies are 17. And so I understand what it's like to be a working mom and try to manage all of these things. And so, one of the things that keeps me up at night now is thinking about healthcare more broadly, and are we actually providing value in what we do when we do fee-for-service medicine? So there are a lot of areas to improve upon, and so it's a great space to be in right now.
Absolutely. And thank you very much for sharing that story. I mean, it's very impressive and touching at the same time, and it's very, very inspiring that this path that you took. You touched on so many things, and I think I'd like to start out. Obviously, as I mentioned in the opening, you had quite a few, say, wins and milestones during your role as Secretary of Health in Louisiana, the hepatitis C reduction, the opioid crisis, drug pricing, and so forth. Could you take us into a few of those that you consider, sort of your most exciting wins, a little bit about them, and at the same time, a word that's, when I read about you out on the internet, a word that pops up continuously is dashboard. You develop these dashboards. You're very fond of course, of these metrics. We have to measure what we're doing. If we don't measure it, we don't know if it's working, and we know nothing about value. Talk a little bit about sort of the dashboard component to some of these successes that you had as the Secretary of Health.
Yeah, look, I'm trained as a health services researcher. I have a redundant public health degree. I have both a master's in public health and then a master's of health policy research, frankly, because it was free, the second degree. But look, I'm trained to understand data. I'm a trained researcher. I've done research as a policymaker. I understand that data are important in terms of decision making. And so as secretary, and then previously, I have always been very deliberate about using data for action, but also using data for decision making and for creating public support around concepts. And a great example of that is the Medicaid expansion. So, this is a Republican state, Louisiana, under former Governor Bobby Jindal, the Medicaid program was hyper partisanized. The opposition to it was ideological. And so what I did was to create a dashboard, not just about counts of people who got Medicaid, but what services they were getting were we saving their lives by finding a precancerous colon polyp or by doing a mammogram? How many cancers have we picked up? How many preventive health screens? We're in the midst of an opioid crisis. How many people got access to substance use or mental health treatment? And i.e., it was over 300,000 people. So lots of people getting 80,000 mammograms, 50,000 colonoscopies, and so on. And then we also did it by region. So if you're meeting with a legislator, even if they might be trained to have ideological opposition to Medicaid, it's really hard for them to say to you, well, look, I don't care that 2,000 women in my district got a mammogram, and if not for Medicaid, their cancer wouldn't have been found. I mean, so I feel like it's sometimes, look, and we've just come from a Trump era where data are just made up or meaningless, and people that are scientists or professionals are attacked. But I found that using data was an effective tool at gaining support. And in fact, we have incredible public support for Medicaid. It's over 80% in a very Republican state. Another example is that I founded the first Office of Health Equity in the South in a health department. And one of the things we did was to have a focus on health equity and disparities in our data. We had already created the conditions to report disparities by race. And so we were the first state then when COVID hit to be able to show COVID diagnoses by race. So setting the stage for that, helped us with COVID. Maternal mortality is another area, really focusing on one of the things I'm most proud of is the work we've done over the past several years in maternal mortality. Louisiana having one of the highest rates of maternal death in the developed world. And I'm proud to say over the past 2 years, we've been able to reduce by 60% what is called maternal morbidity. Morbidity is the precursor to mortality. Morbidity means someone got very sick. They needed several transfusions. Some terrible event happened to them in the hospital. 60% reduction by focusing on it, because if you can't measure it, you can't manage it. And as the governor liked to say, the other reason to dashboard things is that if you need funding or you're asking for federal resources, if you can show the extent of the problem, you have more of a compelling case to get resources to solve it. So, again, I think I've always tried to use my health services researcher background as fundamental. And also, look, if something doesn't work, don't do it. As much as I would love to solve the obesity challenge for Louisiana, and we are one of the most obese states in the country, there is no data that shows that there is a population health approach to obesity. So we didn't focus on it. We focused on things that we knew had evidence. So infectious disease, we lowered HIV rates to historic lows. We tackled the hepatitis C epidemic. We lowered chlamydia rates. We lowered syphilis rates. These are things that are doable. Smoking cessation can be done. That was an area of focus. So really looking at where does the evidence point to impact, and instead of doing the Pollyanna approach, which is it should work and let's do it, we really took a surgeon's scalpel to it and said, look, let's do exactly what works, and it paid off. We've made some really significant impact in a short period of time in Louisiana.
And continuing that, obviously, you mentioned health equity a few times, and this is a theme that we see coming up across the board with many of our guests. We spoke with Microsoft recently about how they're trying to create their artificial intelligence programs to understand equity better. We took a virtual trip to the country of Rwanda, where they have a new university for health equity, where they're teaching the medical students early on in the game about the concepts and how to apply health equity in their practices. Talk a little bit more about this, if you would, from a sort of Louisiana perspective. And then also you had these core initiatives in breast cancer, colon cancer prevention. Can you talk a little bit about how your push of health equity impacts those programs?
Yeah, I think I'm so proud of President Biden and the health equity initiatives he announced yesterday, and proud of and relieved by the fact that finally we have a president who is calling out issues of racial injustice and health equity, and putting significant light on these issues. My friend Marcella Nunez-Smith, who's who's leading the equity task force, is just a phenomenal human, but also very capable and someone who is going to be able to shed light in unprecedented ways at a national level. It's some of the most rewarding work I've done. Look, I'm a white woman, but I'm also adopted, and I now know through 23andMe and other vehicles that my life would have been different. I would be pumping gas or worse. There's no way I would have been a 4 Ivy League degree recipient if my life hadn't turned out how it did. And I feel very fortunate. And again, I think that no one, based on the color of their skin or where they come from, should have less of an opportunity or get worse care. And I feel super strongly about that. And it's those instances that I mentioned that I've seen inequity, whether it was in a Bronx hospital watching a Latina woman not get an epidural because the anesthesiologist just didn't care, told me, look, it doesn't matter if she has pain, I only get paid $70. It's not worth my time. It's those types of things. Or witnessing when I went to Shreveport, early on in my career as medical director, and there was a Medicaid day, and I asked them, why do they have that? And they said, well, we actually don't anymore. We got rid of it because we don't like how the waiting room looks when those patients are in it. And we especially don't like their children there with their McDonald's dipping sauces. So hearing just racist, horrible stuff like that, and it makes me angry, but when I get angry, I get activated. And so I've just been, was one of the early people in this state. Well, I'm one of the first at the health department, because I know that under Bobby Jindal, we weren't even allowed to show data by race or talk about racism. In fact, about 10 years ago, I wanted to have a brown bag lunch about racism and just invite some open discussion. And I was told that I was a Yankee and I didn't know anything, and how dare I, and that there was no racism in the South, thank you very much, and I didn't know what I was talking about, and we weren't allowed to have the brown bag. So fast forward, I'm secretary, and we established the Office of Health Equity. And look, even a couple of years ago, there were people who said, well, this isn't good politics, Dr. Gee, you shouldn't be doing this, it's an election year, maybe just shove it under the rug, wait till later. Similarly, when we started our maternal mortality initiative, we were the first state to explicitly have an equity goal at the outset. So instead of saying, look, we're going to improve hypertension and improve hemorrhage treatment, we are going to improve equity. And we required that hospitals, measure data by race and talk about race and equity. And we had a lot of people at the first meeting that we had about this walk out of the room, just couldn't. But that is the work. That's the important work, is to create the discomfort, to create the sense of, that people are what I found is that when people understand that something's wrong, they're much more willing to change it. And so those are the crucial conversations that need to happen for lives to be saved and things to change. And that's been one of the greatest opportunities that I've had here, is to have those discussions, to promote. In fact, it was kind of neat yesterday. My former deputy secretary, who's Black, told me, Rebekah, I learned more from you about health equity than anyone I've ever worked with. And you talked about it more. And it just, he thanked me, and he brought tears to my eyes, but I thought about what a wonderful experience it was for us both to have that training. And it wasn't just about the work that we did on behalf of patients. We did a lot of work at the department. It was about understanding. We all did equity training. We all looked at our own attitudes and beliefs. In fact, Mark, my deputy, who I mentioned earlier, who's a pastor, he and I scored the same on the test. We both thought we were super, understanding and culturally competent. Turned out we both have work to do. But those are the really important discussions that come from doing the hard work, the looking into self, and your own experience and biases. And we also looked at it not only as a racial equity issue, but as an other issue. If I'm a young person, I may think because you're an old person, I may make assumptions on your behalf that are wrong. Or if you are in a wheelchair, I may make an assumption about your intelligence, your abilities, your motivations, your aspirations. I could be totally wrong. And so it's about learning that when we're different from someone, if we're going to make decisions on their behalf, we surely need to be aware that we may have bias that impacts our ability to lead and make decisions on behalf of. And I think that was really critical work as well that really changed how we ran the department.
Excellent. Dr. Gee, I was a few months ago, I had the opportunity to talk to Dr. Victor Zhao at National Academies of Medicine, and they had recently created this committee to focus on physician burnout and physician stress. And obviously we don't think about it in the middle of the pandemic. We're all under a lot of stress, but our caregivers as well are going through horrific things. I saw you give an interview recently where you talked about caregivers and this concept of moral injury and stress, this post-traumatic stress from this pandemic. Can you talk a little bit about this topic? And then, of course, as I have you, if you could just take us for a few minutes into as somebody who has run health for a state, and the state's playing such important roles nowadays at this part of the pandemic with vaccine distribution and so forth. Just take us on a little bit of Dr. Rebekah Gee and COVID, please.
Sure. So we are human. Physicians are human, nurses are human. We experience moral distress. We experience pain when we lose a patient. It's distressing for us, but we are treated, I think often as our police and fire and other first responders, as superhuman. And so we don't have the kinds of resources that I think are needed to optimize our mental health. I did write a piece recently about how there are in some professions, especially fire, after action reviews and specific actions that are implemented after a traumatic event. Physicians don't have that. So now I think that we have a lot of work to do post-COVID. You have a lot, for example, a lot of people who have worked in COVID units and worried about their own lives, the lives of their families, losing patients in unprecedented ways, have been there at the time of death, the only person, with having to support the patients without family or caregivers able to be present because of the COVID epidemic. And so I do think we need to really think carefully about how we care for caregivers. And I do think one of the byproducts of not caring for caregivers and our attitudes about their superhumanness. In fact, one of my favorite quotes I like to say is, when I was a resident, I was really sick one day and I was really dehydrated, needed an IV in my arm, but I wasn't allowed to go home. I was told, look, either Rebekah, and I had to see patients with an IV in my arm. It was absurd. And this was at Harvard, and I was told either you're in the hospital or you're in the hospital. And so when you have people that are treated that way, and there is such a lack of empathy for them, there isn't a sense that they are human, that they are in need of care, they might be traumatized. I think what sadly happens is that empathy erodes. People then because they can't care for themselves, start to be less able to care for others. And I do think probably we ought to start thinking about that a lot more. Instead of requiring people to take organic chemistry prior to med school admission, they should take an empathy test. And we should be cultivating empathy, because that really is more important. This case I told you about, the breast cancer, a woman had come in to complain about pain multiple times, and at no point over that 6 months had anyone said, let me examine this breast. That's a lack of empathy. So that's where, that empathy saves lives. And because empathy breeds curiosity. Curiosity means you listen. And so I do think that's important. And then COVID, look, it's been, my skill set honed at the health department. And, not only did I manage half the state budget, I managed the health response to disaster. So the governor, I'd laugh, we'd have, $3 billion budget deficit. And then we'd have, all kinds of political attacks, and we'd be doing something, then a hurricane would hit, and then we'd all have to be in the bunker, doing disaster. So that it trained me, and it has as obstetrics, by the way, because obstetrics, you've got to deal with multiple laboring patients. At any minute, some emergency could happen, and you have to keep it all, or being a mother of five, keeping all those balls in the air. So, COVID I was perfectly prepared for a time like this, and certainly have tried to help our university and our city in any way I can, everything from setting up a vaccine program, helping LSU do that, to helping with testing strategy, to initially in the pandemic, helping to procure personal protective equipment, but also advocating on behalf of our first line workers, grocery baggers and other people who frankly were treated not as essential workers, but as disposable workers, and have really been discussing issues of equity quite a bit. In fact, co-chaired for the governor the Disparities Task Force for his COVID health equity effort. So anyway, I think it's been an interesting time. Everyone's exhausted. My heart especially goes out to the mothers and caregivers who have had to try to maintain their own mental health, their children's and sometimes parents' health, and try to do their jobs. And as you can hear in my house, I have kids here, but also I've had help. So I'm very grateful for that. But it's been a really hard time. And so trying to be also a public communicator has been part of my role, as whether on CNN or MSNBC or Fox or our local TV. I do a radio show every Friday morning, and where I share updates on research, on the vaccine, reassuring people, trying to be a consistent and calm voice from the medical community, as this has all really taken us by storm and changed our lives in unprecedented ways.
As a OBGYN, obviously you spend a lot of time at the beginning of life. Just want to go to the other end now. Healthy aging, the demographic shifts and so forth are a theme we touch on a lot on the show. I was looking at before we logged on today that saw something that Louisiana by 2030, a quarter of the state will be over the age of 60. Any interesting healthy aging related programs that you have in mind or that are currently going on in the state?
I can't speak to that. I ran the Medicaid program, which is largely not a program for individuals who are aging. We did have the Office of Aging and Adult Services in the department. And what I would say, though, is I think I wrote a piece this year on ageism and its impact on health. We've seen ageism as it plays out with our president, with Nancy Pelosi, with other leaders, people who are incredibly competent. We see ageism play out in communities as we've seen the nursing home epidemic and how individuals are put aside, not a part of communities. How we view aging in this country, is different than how Asian countries and some Europeans view aging, where people who are older are so much more a part of the social fabric. So I think we have a lot of work to do in this country. We certainly, as we live longer, we need to think about how to continue to include older individuals and their and accept and add their wisdom to the work that's ongoing. One of the things that I most enjoy professionally and personally is I'm part of a group of women who meet every year, and it's a group to support our careers and our personal lives. I would say the average age of that group is probably 65. And at first I thought, what am I going to get out of this? I'm, at the time I was 41, but it's been one of the most rewarding experiences because I get to download this incredible knowledge and decades and decades, cumulatively hundreds of years of experience, and learn from mistakes and wisdom. So I think we need to do a lot more to think about how we add joy to the lives of people who are aging, how we include, similar to what we've done with the disability community, frankly. I think we had a very strong lobby for the disability community in Louisiana, which resulted in some really wonderful things like inclusion, less institutionalization, focus on quality of life. And I advocated for a similar type of effort on behalf of aging and adult services for older folks. And the nursing homes opposed it, and the bill failed because the nursing homes were worried that if advocates for older people had a chance to speak, they would say, look, we should have less nursing homes, or we should have more options. So I do think that that was a unfortunate political situation here, but it is not unique to Louisiana. And so we need to think about how can companies and other individuals who want to care for older folks make money, but do it in a way that also values the lives and preferences of the older individuals who need to use those services.
Dr. Gee, coming back to you, at the beginning you told very touching stories about your mother, your fiance at the time. Any other important influencers, mentors that you want to mention or shout out to that have been sort of alongside you as you've had this amazing journey so far? Take some time to mention them and whoever you want.
Yeah, I mean, my dad is the first and foremost. I mean, he was a single parent, after my mom died. He is a university president. He has been since he was age 36. He's led some of the most preeminent institutions in this country, Brown, Vanderbilt, Ohio State twice, University of Colorado, West Virginia twice. He's an incredibly self-effacing, funny, inclusive person who I just can't think of a better example. Someone who treats everyone with dignity. It doesn't matter if it's the person who's doing custodial work or the person who is the full professor or a board of trustee. He is kind and he remembers everyone, their families, their names of their kids, when their birthday is. I mean, he is truly an extraordinary man, one of the greatest humans I've ever met. And that's my pops. And then you've got professionally and more recently, I would say I've got a tremendous mentors, but someone like Josh Sharfstein, who's at Hopkins, who is a friend that also helps coach me and has coached countless others in similar career trajectories. When I was secretary, helped me with various initiatives. Governor Edwards, the longer I have ended my term as secretary almost a year ago, and as I reflect on his leadership, both inclusion of women and people of color, the way that he managed disasters, always kind, never punitive, extremely short memory. When I say that, I mean someone who has tremendous backbone. You could insult him, you could slight him, but if working with you tomorrow means that the people of Louisiana will be better for it, he will forget about it and move on. I mean, what an amazing guy. So I've had the opportunity, my mentor, Susan Blumenthal, who was the first head of an office on women's health. I've had, and then I think one person who I got to meet who had a huge impact on my life that I didn't know well, but was just one of the highlights of my life, was that I happened to be in South Africa in 1996 and at a event honoring some of the work that Nelson Mandela did. And I was near the front of the audience. He happened to come up to me and hold my hand. And that was a transformative event. And most of the things that I say as my mantra come from Nelson Mandela. I think of him. And whenever I've had a challenge in my life, I think, wow, if he could get through 36 years of prison, and have the wherewithal to rebuild a nation and forgive. I mean, clearly I can do med school, or you name it, put a sentence after that. Clearly I could, look at his example. So I just think someone who's alive, that was alive and I got to meet. I can't think of someone who exemplifies leadership better than Nelson Mandela.
Outstanding story. Outstanding. Dr. Gee, it's been a real pleasure talking to you and listening to these stories, and really wishing you the best for everything you're going to be doing moving forward now. For everybody that's listening to this particular podcast, there's going to be watching on the YouTube channel. You've been listening to Dr. Rebekah Gee, clinical professor in obstetrics and gynecology at LSU School of Public Health and Medicine, chief executive officer of LSU Healthcare Services, and former secretary of Louisiana Department of Health. Dr. Gee, thank you so much again for your time. Thank you for sharing all your knowledge with us. And as we say, thank you for taking time to create a better tomorrow for all of us. It's been very inspiring listening to you.
Thank you, Ira. It was a delight to be with you. Thanks for having me.
Absolutely.